Good afternoon, ladies and gentlemen. My name is Sally, and I will be your conference operator today. At this time, I would like to welcome everyone to the CLIN NCC National Learning and Action Network call, Driving Safer Care. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you'd like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you'd like to withdraw your question, press the pound key. Thank you. I will now turn the conference over to Brianna Goss with the CLIN NCC. Please go ahead.
Good afternoon, everyone, and thank you for joining for the National Learning and Action Network event, part of our quarterly Sharing Knowledge, Improving Healthcare series. We're very happy to have you with us today as we discuss the important topic of driving safer care. My name is Brianna Goss, and I am a manager of quality improvement for Telligent. I also work with the Quality Innovation Network National Coordinating Center, or the QIN-NCC. Just a few reminders and housekeeping items before we get started today. Again, thank you for joining us here in the WebEx Event Center. If you haven't already joined the event online, you will need to access your registration confirmation email and registration ID in order to log into the WebEx. My colleague, Kathy Macri from the Quality Innovation Network National Coordinating Center, will be monitoring our WebEx chat board, so please be sure to participate as we go along and feel free to ask your questions. Slides, resources, and the recording from today's session will be posted to QIOprogram.org website under the News and Events tab. Some of the resources you will see are already posted here. Let's start by reviewing today's agenda. First, we'll go over the continuing education or CE details. Then I will introduce each of our 3 speakers today. Melissa Dorsey with the Centers for Medicare and Medicaid Services, Carol Moss with Niles Project, and Dr. Jason Newland from the St. Louis Children's Hospital and Washington University. There will be 2 separate facilitated discussions, one after Carol's presentation and the other following Dr. Newland. Finally, I will wrap up with a reminder to complete our post-event assessment and a plug for upcoming calls. So I'd like to take a moment to remind our participants about the purpose of this important series of learning and sharing events. Without reading all of the content on the slide, I'll just mention a few high points. The audience is very broad and inclusive of a variety of healthcare provider types, partners, and patients. The purpose of the call is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. As for expectations, we ask that you think of actionable ways to implement the ideas and concepts presented today and make a commitment to share this information with your own team. And finally, we are always open to new ideas and suggestions for topics to bring to this audience. So please feel free to send your ideas through the chat and or through the post-event assessment. And now, to address the direct purpose of today's event, we are working to prepare healthcare professionals, partners, and patients to implement effective and safer care strategies. We hope that you'll identify opportunities for improvement in your own work, with an overall focus to improve the quality of care provided to Medicare beneficiaries. Again, we are hoping to make this an interactive presentation as much as possible, which can be challenging given such a large audience. Therefore, we ask you to commit as individuals to be attentive, active, and actionable, thinking about all the ways the content is relevant to your work and priorities. We welcome your active participation by clicking the green check in the WebEx application. Click the conversation bubble and choose yes in the drop-down menu. We are also very excited to now be offering continuing education credits to all attendees for participating in today's session. Based on feedback provided during our last event, we'll be offering credit to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We're also offering certificates of attendance. Should you have requests for additional accreditation types, we welcome those suggestions as well, again, through the chat or in the post-event assessment. So a disclaimer from our partnering provider, CRW Associates. This activity awards 1.0 AMA credit hours for physicians and physician assistants. We're offering CE/CEU credits for physicians, physician assistants, pharmacists, and pharmacy technicians. This activity also awards 1 contact hour for nurses and 1 continuing professional educational credit for dietitians. This slide contains the accreditation statements for those entities. For registered nurses, nurse practitioners, and dietitians, certificates of attendance will also be available. We would like to report that the planners and faculty for this event, CRW and Associates and Halogen, do not have any relevant financial relationships to disclose, nor was any commercial support received for this activity. Please reference the slides for the full disclaimers and disclosures. In order to apply for continuing education credit, you must have attended the entire event, complete the post-event assessment and the CE evaluation that will appear after exiting this WebEx session. Note that the CE evaluation can only be accessed by following the application site hyperlink at the end of the post-event assessment. In an attempt to get an idea of what types of organizations are represented on this call, we invite you to respond to a poll indicating where you are working. Another thing we're interested in is whether or not you would claim CPHQ credit if it were offered. So WebEx, would you please open the poll? So let's go ahead and have everybody complete the poll that is up on your screen. And we have about 20 to 30 seconds to do that. And once the poll is closed, if WebEx could please bring up the results. Okay, so let's see who we have on this call with us today.
13 seconds left.
Oh. Okay. So it looks like, as we expected, a very diverse range of individuals who are participating on today's call. It looks like the majority are either hospital or QuinnQIO staff, and it looks like about half of the participants would be interested in claiming CPHQ credits. So by the end of the call today, you should be able to describe at least 3 ways that deaths are caused by antibiotic-resistant infections. Describe at least 3 ways that deaths caused by antibiotic-resistant infections, bacterial disease, and sepsis can be prevented. Identify at least 2 resources that can be utilized by providers to drive safer care. And explain how you can participate in the appropriate use of antimicrobials and of infection control in vaccinations and in the food you eat. So now I would like to introduce our first speaker. Melissa Dorsey is the Excellence in Operations Subject Matter Expert and Contracting Officer Representative for the Quality Innovation Network National Coordinating Center at the Centers for Medicare and Medicaid Services, or CMS. Melissa will talk about the CMS quality strategy and provide an overview of CMS's efforts around driving safer care. Melissa, the floor is yours.
Thank you, Brianna. Good day, everyone. If you can just advance to the next slide. Great. The CMS quality strategy guides the healthcare transformation activities from the federal, state, and local levels, including those that are working within your community. The CMS strategy prioritizes 6 goals for success, which you see listed there. Now, the topic for today's National LAN, Learning in Action Network call, aligns with the CMS quality strategy goal to make care safer by reducing harm, cost, and delivery of care. The healthcare-related errors harm millions of Americans each year and add billions of dollars to the healthcare costs. 2 prominent examples include adverse medication events and healthcare-associated infections, or also known as HAIs. These types of HAIs include central line-associated bloodstream infections, also known as CLABSI, the catheter-associated urinary tract infections, or CAUTIs, the surgical site infections, or SSIs, as we also know it, and the ventilator-associated pneumonia, also known as VAP. Next slide. So the objectives surrounding this goal to make care safer include improving support for a culture of safety, reducing inappropriate and unnecessary care, preventing or minimizing harm in all settings. Now, CMS aims to achieve these objectives by doing the following: improving communication among patients, families, and providers, empowering patients to become more engaged in their care, also by promoting better coordination of care within and across settings, implementing evidence-based safety practices wherever care is provided, as well as supporting payment systems that incentivize smarter use of testing, treatments, and minimizing harm from inappropriate care. Next slide. So today you'll hear from two very passionate speakers. Their missions focus on reducing harm in delivery of care, primarily by avoiding preventable HAIs. Again, those are healthcare-associated infections. You will get to hear more about some smart strategies and some promising practices that have been implemented to improve outcomes, also to improve patient safety. As you are listening to Carol and Dr. Newland, consider your journey to reduce harm in the delivery of patient care, where you have come from, where you are now, and where you are going. Consider Carol's story and Dr. Newland's data, what you can do to make the most out of your journey, and also provide the safest patient care. Again, I'd like to thank you all. And Brianna, I guess I'll turn the floor back over to you.
Thank you so much, Melissa. We really appreciate your insights from the federal perspective. It is now my pleasure to introduce our next speaker. Carol Moss and her husband Ty are founders of Niles Project and parents of Niles. Carol will share Niles' story and discuss the accomplishments of Niles Project and how Niles Project or similar organizations contribute to safer delivery of care. Carol, the floor is yours.
Thank you so much. I'd like to start with introducing a clip from one of our concerts to give you an idea of what we do for public awareness.
Every time I get on stage with this band, I know how grateful I am to be doing that it's an epidemic. We've learned that it's preventable. And we've learned that we can, as the people of the United States, make sure that our families get safe health care. We're here to share everything that we've learned as we've worked with great organizations like the Consumers Union and RID, the Committee to Reduce Infectious Deaths. We work with state legislators. We work with California Governor Schwarzenegger, and we are now focused on making sure that the United States has the benefits of preventative measures that have proven to be life-saving.
So I hope you enjoyed the clip. It's a couple years old. In thinking about myself, I don't think I would have gone to a concert that would be for Superbug Outbreak. So we know people love jazz. So that's just one of the ways that we've been able to bring important information to the communities. So hello to all of you, and thank you so much for joining. For the last 10 years, God has led my husband Ty and I on a journey to understand how and why our son, Niall Calvin Moss, died at the age of 15 from a preventable infection he contracted at the top children's hospital in Orange County, California. We are here to share what we learned with all of you in hopes of driving safer care. We entrusted 2 prominent children's hospitals with the life of our son. The first one failed the test of cleanliness. Niall contracted MRSA at the top children's hospital in Orange County as an outpatient. He was there for only a part of the day. He met with physicians and had an MRI on Easter weekend, 2006. The CMS condition of participation for infection control states that hospitals must provide a sanitary environment to avoid sources of transmission of infections and of communicable diseases. Next, we visited a local pediatrician to help us understand why Niall developed flu-like symptoms after his day of testing at the hospital. He had a sore throat, a fever, a headache. They tested him for sore throat, and the test came up negative. But this doctor did not take his symptoms seriously. Had I known the prescription he handed to me was for strep throat, and that we had just been informed that his test was negative, I would have challenged the physician to justify the antibiotic. That was the last 3 hours that Niall and I would be in public together, waiting for an antibiotic that was useless. The second children's hospital failed to take Niall's sepsis symptoms seriously. Niall struggled to breathe for 5 hours before being admitted. He then struggled for breathing for another 5 hours before they administered a single drop of antibiotics. Niall was admitted with necrotizing pneumonia. Clearly, this hospital let us down as they delayed the appropriate treatment quickly. Niall was reborn in heaven early morning, April 17th of 2006, the day after Easter. Clearly, this hospital needed a crash course in many areas of learning, antibiotic stewardship, sepsis, etc. We were unaware of the global threat of antibiotic resistance. And we were not aware of our nation's challenge of preventable hospital-acquired infections, and we had no idea of what sepsis was or even how to spell methicillin-resistant staphylococcus. It was just all new to us. We've come a long way over these last 10 years. Our national focus on patient safety has taken center stage, and we should all be excited about the new direction. I know I am. For far too long, healthcare-related compensation has been based on the quantity of care, a dangerous concept for obvious reasons. We have come a long way. We have talked with physicians at the end of their careers who feel they have lost their souls by conforming to healthcare norms and not fighting for change. Now we hear from hospital CEOs that are reaching out and helping to drive mandates and legislation that will finally require trustees of hospitals to fund the appropriate resources to protect patients and healthcare workers from harm. Yes, we're excited about it. We're in the middle of this change, and it's great to be a part of driving safer care for all. This conversation today is a perfect example. I'm so happy to be here. How did we get here? We got here with people sharing personal stories. People standing up and sharing their own experiences, the good and the bad for the greater good. We knew that we didn't have everything we needed, but we developed a nonprofit called Niles Project, and we are here to inspire a culture of safety, to share awareness, provide education, and focus on prevention. Prevention. We all know that the CDC has the best practices of prevention. Why aren't all hospitals using them? We're here to also structure the appropriate action that's required, support a revolution of change, and we urge you all to become a part of this solution, because each one of us is needed for success. Patients and parents, you need to reach out for information. It is your responsibility to know the history of physicians that deliver your care, to know the quality and performance ratings of your local hospitals, and they're working hard to improve, to research detail about the antibiotics prescribed before you take them. This is an interactive sport now. We all need to participate. There were so many important facts that we did not know about that could have changed the outcome for Niles, and that's why we're here. We built Niles Project to inform the public and provide awareness concerts like the one you saw, to provide lessons learned, and to actually incorporate the community in the change that we are all involved in. Niles contracted MRSA from equipment that was not cleaned. Trustees and administrators, those who clean rooms. Environmental cleaning is crucial to patient safety. Investing in quality will save lives. Healthcare givers, it is a great time for those of you who always wanted to make a difference in the lives of others, because there is a revolution happening now that healthcare workers are leading from the inside out. Speak up if you see an opportunity for improving care. Speak up if you see something that you can help to prevent harm, and make sure you're heard. Now we know about antibiotic resistance and what is at risk if we don't make big changes. All of you should have a better understanding of antibiotic resistance after watching Mira McKenna's TED Talk on what do we do when the antibiotics are gone. This is one of our world's greatest threats, antibiotic resistance. We are so thankful that in 2015, President Obama issued the executive order for combating antibiotic resistance, because before that time, no one would talk to us about antibiotics. What is MRSA? It was like it was a big secret. Antibiotic resistance. We did not know that nearly 2 million people become infected with bacteria that are resistant to antibiotics, and at least 23,000 of these people die. I've added a link here to share, for you to share, with great information from the CDC on how to protect patients as it relates to drug resistance. Please read this. It's great to share. We are so thankful for Mira McKenna's focus on antibiotic resistance because, quite frankly, it's a confusing topic. But as you should have seen, the TED Talk has become a great educational tool to get up to speed. So now I would like to invite you all to answer a question. And we'll go ahead and use the embedded whiteboard tool here for that.
And we would like to invite you to respond to this question on WebEx. So if you look at the top left corner of your WebEx screen, right above the slide, you should see a little pen button, and when you hover over that, it says annotation. If you click on that, you can access the text tool. So the second button from the top with the uppercase A and the lowercase a, you may click on that, and then feel free to type in your response directly on the slide. and then you'll have to click out of your response line in order for it to show up. Thanks, everyone.
Great.
And also, I was going to mention, if you also wanted to try to put your cursor where there is some white space left, I know there's a lot of people on, but you can also feel free to chat in your response. But this is really great. Thanks, everyone, for participating.
Excellent. Thank you. So, Niall's project also has done some things that I want to share with you because my husband and I started and we're just regular people. So we realized that there were things that we could do in changing policy to help save lives. So in California, we did some research and we found out that, transparency and awareness about this is probably what we're lacking. And I know, and my husband knows that we had never heard of this. So we teamed up with two legislators on two legislative bills that became law in 2008. One of them is called Niall's Law, and this requires all California hospitals to report their antibiotic-resistant infection rates and share it with the public. So on the next slide, let's see, we're not able to change slides yet. Let's see if we can. Oh, keep going. Keep going. There we go. So SB 158 with Senator Flores requires hospitals to adopt an infection prevention program, and that includes cleaning and all kinds of things of the CDC guidelines. So these bills became law, and we were so grateful. We thought it was a miracle, but we knew that everyone wanted to make sure that we have the visibility to find out what is the size of the problem, and then what preventative measures are working. So now we've got a baseline, and we're focused on this. We continue to drive and share the importance of Niall's Law, and if you turn to on the next slide, you'll see a very exciting result of this law. So if you can dial this into Google, and if you type in My Hospital 411 infection map, now this just reflects the state of California because the legislation was for California, but this is serving to be an incredible tool for the public to be able to go in, take a look at their hospital. You can just click on each hospital and pull up their profile. And this is something that is so usable, so you can see if some hospitals are having problems with infections on hip and knee surgeries, then perhaps you can find another hospital that has taken care of the issues within that hospital. So we are so excited about this and grateful for the visibility, the transparency, and it's definitely helping to save lives and improve healthcare. So now we have some of the lessons learned that we'd like to share with you about hospital-acquired infections. To some of the beneficiaries who haven't worked in healthcare, many of us have been told throughout our lives that, Grandma, she got a staph infection, and that's just what happens. But what we do know, and what healthcare workers know, is that hospital-acquired infections are preventable, and there are many hospitals that are doing a great job at implementing the CDC guidelines. But then, if you take a look at what happened with Ebola a couple of years ago, the challenges that occurred were a direct result of hospitals not following the CDC guidelines for infection prevention. And if these kinds of things continue, and if we're unable to manage the antibiotic-resistant infectious diseases, it would be a good idea to see if CDC guidelines can become mandatory with enforcement. Antibiotic resistance is caused by the overuse and misuse of antibiotics. And what else we learned was that Niall would be here today had the professionals taken his symptoms for sepsis seriously. The other thing that's very critical is the need for rapid testing that's on-prem for all of us because early diagnostics and rapid, accurate treatment is a cure for these kinds of infections. Also, we know that with sepsis, 254 million people die each year from sepsis, and these infections are preventable. We just need to take their symptoms seriously. Sepsis is the body's overwhelming effect to life-threatening response to infections, which can lead to tissue damage, organ failure, and death. It is difficult to predict, diagnose, and treat. Patients who develop sepsis have an increased risk of complications and death and face higher healthcare costs in longer term. We talked with a patient who had sepsis and realized that I wish that someone had told me, the last person in the wheelchair that wheeled me out to the car, I wish someone would have said, if you have a fever or if you have low blood pressure or if you have flu-like symptoms, immediately get back in touch with your doctor because this could be a result of treatment. If that was the last thing that she heard, she knows that things would have turned out better for her. Some of the drivers for our new culture of change are the reasons why we're here today. Pay for performance is a critical component. The ability to have great quality of care compensated. That's what should be the focus. Accountability and public involvement. We are all a part of this great new revolution. For providers, be the new revolution of change. If you see something, say something. Providers provide anonymous tip lines and different ways that you can report things if needed. But go to your hospital leadership and let them know. I've also included some information here for the beneficiaries. There are links attached for ProPublica that gives you a national surgeon scorecard and Consumer Reports that can give you a scorecard on medical boards. They're the ones who are oversight for physicians and can give you a good understanding of that. Some of the work to be done on infection prevention, environmental cleaning, and sepsis prevention to reduce the use of antibiotics. We feel national certification training is critical. I know how we all take online on our phones. We do ethics compliance. If there's some way that we could implement simple, downloadable online or on phone or mobile national certification training and updates for all, this would have a deep effect on the improvement of lots of things. Rapid diagnostics, antibiotic resistance, antibiotic stewardship, and sepsis are many of the topics that we should cover. The last couple of slides include additional resources for you. The second to the last slide includes my information. It's been a pleasure talking with you today, and we appreciate all the work that you're doing, and we know that we can pull this together, and let's get it done together. Thank you for your time.
Thank you, Carol. Let's go ahead and reflect on what we've heard by answering a couple of questions in the chat. So what are your key takeaways from Carol's presentation, and what did you hear that you can apply to your efforts to address healthcare-acquired infections? So go ahead and enter your answers to these questions in chat, or if you have questions for Carol, you can enter those into chat as well, or we should have time at the end of our next presentation to ask questions of both of our speakers. Thank you again, Carol. We appreciate your perspective and insight on driving safer care through public health education. It is now my pleasure to introduce our second speaker. Dr. Jason Newland is the director of the Antimicrobial Stewardship Program at St. Louis Children's Hospital. He is also Associate Professor of Pediatrics at Washington University. Dr. Newland will talk about what links antibiotic resistance and their outcomes by speaking to the role of Antimicrobial Stewardship Initiative. Dr. Newland, the floor is yours.
Thank you, Brianna, and I appreciate the opportunity to speak with you all today. And I just want to really thank Carol for sharing the story about her son, Niall, and being a leader in driving some of the important changes that we must continue to do as we continue to fight this worldwide epidemic, or a really pandemic, of antibiotic-resistant infections. And as a pediatric infectious diseases provider for the last 10 years, I unfortunately can tell you a number of cases of caring for patients that have suffered and even died of resistant or antibiotic-resistant infections that we couldn't treat. And the story that comes to mind most often for me was a little neonate that was born at 24 weeks of age, and many of you are in hospitals likely that care for these sorts of babies, and it's amazing what technology and medical care and medical advancements has allowed us to take an infant that was born at 24 weeks that might be, less than a pound, and they survive and do well. And in this instance, this child was doing great, was 4 weeks into their life, and then they developed a central line infection. And that central line infection was with Pseudomonas aeruginosa, which is a gram-negative bacteria that we can treat with antibiotics. And so we gave our first-line antibiotic, known as Sepsis. Many of you probably recognize that antibiotic name and have used that. Well, the child did well, got better, but unfortunately developed the Pseudomonas central line infection yet again. And now it was resistant to Sepsis. So now we're using meropenem. In some people's minds might be a last-line agent for such a bacteria, but we do have other agents, thankfully, which one is called colistin, which is more a last line, and it's an older drug. And unfortunately, this child developed another Pseudomonas infection and then succumbed and passed away while receiving colistin. And that's just one of the many stories. I could tell you other stories that have happened in the past weeks, and we heard, I think, a more poignant story by hearing from an actual mother who lost a child of methicillin-resistant Staph aureus. So the reality of this is we see these infections, and they impact everyone, and they truly impact loved ones much greater than what I can ever imagine from the position I'm in. So with that, I have one disclosure, which is a rapid diagnostic company I consult for, but otherwise, you heard this stat from Carol. 23,000 Americans die annually from an antibiotic-resistant infection, and that is an underestimate. 2 million Americans are infected annually. Again, this is annually, with an antibiotic-resistant infection. And while we talk about antibiotic-resistant infections, there's other side effects to antibiotics, one of which is C. difficile infection, or Clostridium difficile infection, a horrible diarrheal illness that 250,000 Americans suffer annually. And this CDC estimate suggests 10,000 die annually from this infection, though a more recent estimate suggests up to 29,000 die from an antibiotic adverse event known as Clostridium difficile infection. So again, it impacts us greatly, the use of antibiotics, the inappropriate use of antibiotics in regards to both adverse events and antibiotic resistance. So you look at this slide, and if you orient yourself to this slide, you see on the y-axis you have mortality. On the x-axis you have a number of different studies. The first two on the left represent bloodstream infection studies, and on the right are those that have pneumonias that occur while in the hospital. Most notably is that VAP, or ventilator-associated pneumonia. And you can see in the light blue there's adequate therapy, and in the darker blue is inadequate therapy. So you can make a lot of stories, and unfortunately Carol has lived through one of these stories where you have a child that comes into the emergency department, maybe with a severe septic event or sepsis, and you do everything that you have to do, and you get the cultures and you start them on an antibiotic, and maybe you start them on that antibiotic like ceftriaxone, a drug that will treat E. coli that's susceptible most of the time. But what happens if it's the wrong antibiotic? What happens if that E. coli actually is one of those E. coli that's resistant to ceftriaxone? You're wrong, and it takes about 30 hours to probably 24 to 30 hours to know the actual susceptibilities at this time. And so it makes sense that your mortality is greater when you have a child that is that sick coming into your emergency department and you don't give the right therapy. Despite the fact that it seemed right all the other time, but now this is where resistance plays. And this is the data that supports that. And you all have seen that and lived it, and unfortunately, those even on this phone have had to live that as well. So So this is a problem that is ever growing, and it's even more recent. Many of you probably have seen these headlines. The superbug that doctors have been dreading just reached the U.S. Antibiotic-resistant bacteria give urgent warning. Common infections could become untreatable. Dangerous new antibiotic-resistant bacteria reach U.S. And I don't even show why they're saying that. I don't give you a specific bacteria, but what this was related to was a colistin-resistant gene that now is found in common gram-negative bacteria like Enterobacters and E. coli and such. But this is not really new news. We've been dealing with this. Yes, it's another example of how bacteria are smart and evolve and make the treatment so much harder, and it's just another huge call to action that we have to be doing more. So why? Why is this happening? Well, if we just look at our own country, we know that approximately 30% of antibiotics used in hospitalized patients are inappropriate. Some would suggest it's up to 50%. We also know that if we look at outpatient prescribing, which is by far and away some of the largest group of prescribing in human medicine, is that a third, so 1 out of 3 people, will receive an antimicrobial prescription in the outpatient setting that's inappropriate. And then finally, we know that a large proportion of our antibiotic use in the U.S. has been dedicated to the growth, promotion, in animals for our food industry. All of these things matter. And it is a whole One Health approach that's needed for us to combat this problem. So with that, we as organizations still need to be striving to be high reliable organizations. We need to be striving to put safety as the capstone to all of the things that we are doing, and think about those high reliable principles listed in this slide. Preoccupation with failure, reluctance to simplify, understanding the operations. This is all infection control, which impacts antibiotic resistance. Preventing infections prevents using it. It involves doing the right hand hygiene, whether it's in the outpatient clinic or in the inpatient setting, or in the long-term health care. These are all important things, and these principles work in antibiotic stewardship, infection control, quality improvement programs, as you all know, that will make our hospitals and our clinics safer, as well as I think will also impact our antibiotic-resistant infections in the end. So the solutions to this pandemic of antibiotic resistance, well, I think first and foremost, something that is near and dear to my heart and something I'm very passionate about is the development of antimicrobial stewardship programs in all healthcare settings. And when I say antimicrobial stewardship programs, it's essentially programs that will monitor the use of our antibiotics and essentially all our antimicrobials. These programs will take resources. And the Center for Medicare and Medicaid Services has proposed a new rule to say we have to have active stewardship programs. And those programs will need resources to do this well, just like infection prevention and control. We need better diagnostics. Carol stated it perfectly. The more rapid we know, the more rapid we get them the right treatment. That saves lives. We have to have better diagnostics. 3, we need to know best length of therapy. I saw that and someone wrote that in, durations of therapy. We still don't know some of the best lengths of therapy. We do need to encourage people to take all their medicines, but when is the right therapy? Because we know too much antibiotic can also drive resistance. We also know too less of antibiotic, we might not treat the infection, which also can contribute to resistance. So we need to have the studies, we need to fund the studies to know the best length of therapy for just common infections, such as pneumonia in children. Again, we talked about this. You heard this very well described by Carol and her experience with Nile and what happened. And it is the reduction of hospital-acquired infections. Vaccination. You cannot ever underestimate the impact of vaccinations. Preventing annual influenza prevents a whole host of use of antibiotics, as well as super infections with bacteria such as MRSA. We need to decrease the antimicrobial use in agriculture. That's going to take us collaborating with those in the agriculture industry and identifying the areas like growth promotion that antibiotics have to be stopped. And finally, we need to support the companies that can develop new antimicrobials. They're not developing them because it's not financially beneficial for them. So we have to figure out those strategies, and I think the government is doing a good job to help stimulate that. But these are the things we need to do in the future. So my call to action for you all, in all the positions you're at, support the development of antimicrobial stewardship actions and programs. Support those people that want to do this work. Empower your healthcare workers to be able to prevent infections. Remember those high reliability principles in doing this. Vaccinate, vaccinate, vaccinate. Wash your hands well, right, all the time. And while this should be two separate points, I suggest you support those farmers in the food industries that are raising animals without or are judiciously using antibiotics for ill animals. These are the things that are needed for us to combat the antibiotic resistance pandemic that we're dealing with currently. Thank you very much, and I look forward to the questions. Back to you, Brianna.
Thank you so much for your presentation, Dr. Newland. At this time, I would like to open it up for questions and comments for our speakers. I again invite Kathy, our chat facilitator, to share about the conversation happening in chat and any questions that have been posed there. Sally, would you mind reminding the audience once again how to ask a question?
Certainly. If you would like to ask a question, please press star, then the number 1 on your telephone keypad. Again, that is star 1 on your telephone keypad. We'll pause for a moment to compile the Q&A roster.
And Kathy, are there any items in chat that are worth pointing out at this time?
I think just the feedback on the other ones, it was very clear that the audience thinks that communication is the key. You know, we need to be aware, we need to ask questions. There were several that said that it was important and kind of eye-opening that if you see something, say something, that comment that Carol said. A lot of others supporting duplicate questions about being voted on hand washing and environmental control. I did see one question. It was, so how do we ensure appropriate use 100% of the time?
Repeat that again, I'm sorry.
It says, how do we ensure appropriate use of antibiotics 100% of the time?
I think that's the goal, right? We need to develop the ability to be able to know what is that 100% appropriateness. Because we're not saying to get rid of antibiotics. Antibiotics have revolutionized healthcare. So that's going to require a lot of continued development of our antimicrobial stewardship programs, continued collaboration, continued communication with other frontline providers, such as those in the intensive care units, our emergency departments, our urgent care settings. But I think someone also mentioned it well, right? It needs to be also a collaboration with those patients and families so that they're asking the right questions. To say, hey, why do I really need this antibiotic? Or, hey, I'm not expecting an antibiotic at this visit, provider. Therefore, you don't have to feel pressure that I'm going to go somewhere else to get one. So I think these are all important factors for us to reach 100% appropriateness.
Thank you. Sally, are there any questions in the queue?
We do. We have a question from Sunshine Hicks. Your line is open.
We were just discussing, we have started a stewardship program and we're working on getting our policy, but once we collect all of this data, what do we do besides taking it back to our stewardship program and trying to figure out, do we use epidemiology reports to trend as a hospital? I guess, what is our overall goal other than figuring out when we're using and if we're using them appropriately?
Such a great question. I think the first thing, right, is that we know that the increase in our antibiotic use in our hospitals are inappropriate, most likely around 30%. So right now you can use some common metrics like days of therapy per 1,000 patient days to see where you are.
Okay.
And then look at reducing that days of therapy, because currently the assumption, which I think is fair, is that initial reduction, you're going to be reducing inappropriateness there. Currently in work with the CDC, we're trying to identify areas like maybe we focus on urinary tract infections or how we treat central line infections to look at more of that appropriateness question so that we can say, okay, our percent appropriateness in treating our methicillin susceptible Staph aureus central line infections is 100% because we're not using vancomycin to treat it. because that would be inappropriate. It's those sorts of things that we have to work to. So what I would encourage is, one, getting to where you know your days of therapy per 1,000 patient days, and then following what your C. difficile rates are, because that's it's been shown in the literature to be impacted by reduction in antimicrobial use, especially broad-spectrum use, such as like the fluoroquinolones, like ciprofloxacin, cefepime, meropenem, those sorts of antibiotics. And following those in line is a way to go. And then I think it's going to be key for us in all of our stewardship programs to track the data, as you mentioned, and report it not only to the quality improvement programs, but also to our frontline providers. We definitely know through literature in the outpatient setting that physicians specifically like to compete with one another, and that if you have them show their kind of appropriate use or percentage above use with somebody else, they want to get better toward where everyone should be. So these are the strategies we'll have to use in the future. I hope that answers your question.
Yes, that was very helpful. Thank you.
And please feel free to contact me if you want to talk more about it. I'd be happy to talk more about these aspects of stewardship.
Thank you.
You're welcome.
Again, if you'd like to ask a question, please press star 1.
And Kathy, are there other items in the chat or other questions that people have posed?
We do have a few other ones here. One of them was, what do you mean by commitment to resilience and deference to expertise?
Great question. So, commitment to resilience. So that talks about when you're faced with dealing with kind of like one example would be a resistant infection outbreak, or you have an outbreak of a resistant bacteria, such as maybe it's VRE, vancomycin-resistant enterococcus, and if this is something that you've been trying to do everything you can to prevent, but now how do you handle it? And that you come up with those processes and procedures to do that. The deference to expertise, to me, when it comes to stewardship and antibiotic resistance and even safety, is really got to defer, really sometimes to that frontline provider and that nurse that's out there understanding what the process are. Maybe in regards to sepsis, why is there a delay in getting those necessary fluids or the necessary appropriate antibiotic to learn your system? Because getting the right antibiotics for antimicrobial stewardship is an antimicrobial stewardship effort. Because you want to get the right antibiotic at the right time. That's all about antibiotic stewardship. And so that's where that deference really makes a difference.
This is Carol. To your point, Jason, that's exactly the challenge that we have in front of us. And that is, while people will take longer to determine if an antibiotic is necessary, we can't take too long on the right appropriate care and just assuming it's sepsis if it looks like sepsis.
Carol, you nail it. I think that's what the thing about antimicrobial stewardship that people sometimes forget is that it's still the right drug at the right dose at the right time. And for sepsis, that's quick. And then for the right duration, that's stewardship. So you're right. I mean, that's a key thing we have to look at and remember.
And Brianna, if we have time for another question, I don't know if we have any more on the lines, but another question was, aren't vaccines for viruses? Are you saying if we vaccinate, then they won't get antibiotics by mistake?
So that's yes, you nailed it. That's part of it, right? So what we see is people, especially with influenza, they come into the clinics and they have a high fever, and they're shaking and chills, and maybe they have a lot of runny nose, and then someone goes, maybe they have sinusitis, when the whole time it was influenza. Another one would be pertussis. Someone comes down with a horrible cough that's been persistent for a long time, and while you need to use azithromycin initially to treat it, they might have gotten amoxicillin at first. But yes, the more we can prevent even viral infections, we can prevent inappropriate use of antibiotics for viral upper respiratory infections. But secondly, we know that stuff like influenza you can have super infection. Measles, while we don't see it, though in some parts of the country now we've seen different outbreaks, measles, it can get complicated by Streptococcus pneumoniae, a very common bacteria. So yes, these will matter on twofold, preventing superinfection as well as preventing unnecessary antibiotics for upper respiratory infections.
And there are no further questions on the phone line.
Okay, well, we're going to wrap up questions there. For those of you who maybe had a question and we did not have the opportunity to answer it today, we are having a follow-up event for this call on September 6th, and your question will be answered at that time. So now that we've actually heard from our speakers, I have an ask for all of you. First, become empowered. I know many of you are healthcare professionals and quality improvement professionals, but if it came down to it, would you really know how to become involved in your own healthcare? What about your family's healthcare? Dr. Newland encouraged you to support antimicrobial stewardship actions and programs, to vaccinate, wash your hands, and support farmers who raise animals without the use of antibiotics. Carol mentioned some excellent resources, and we will post those on the QIO program website. I encourage you to review the resources and share them with family, friends, colleagues, and partners. Carol shares some best practices that you can start applying immediately. Next, do you have a story to share? Have you or a loved one experienced successful delivery of safe care? Is your organization implementing practices for providing the safest possible care to your patients? On the other hand, what are some challenges? Share these with the Quinn NCC by emailing Nikki Rosellis. Kathy will include her email in the chat. These stories can help guide content for our follow-up event on Tuesday, September 6th. As we mentioned earlier, we'd love to hear topics from you all for future offerings through this venue. If you have any needs or any ideas, please send them through chat or email us at quinnncc@area-d.hcqis.org or provide your ideas in the post-event assessment. To ensure we have the opportunity to engage with you all again related to your actions and activities as a result of today's session, we would like to invite you to join us for a follow-up event on Tuesday, September 6th from 3 to 4 p.m. Eastern Time. We're fortunate to have the speakers from today's call joining us for that event, and we want to hear from you all the things you've accomplished and or started. Note that registration for this event will be required as well. We would also like to invite you to join us for the next formal National Learning and Action Network event on Tuesday, November 1st, 2016. The topic will be focused on promoting effective prevention and treatment of chronic disease. Finally, please take a moment to complete our post-event assessment. Your individual feedback helps drive our future calls. We review and consider each and every response and all of your feedback. As a reminder, if you'd like to claim CE credit for this event, please complete the CE evaluation found at the end of the post-event assessment, the link for which will be entered into the chat. Once again, contact Nikki Rosellis with any questions. Any last questions, please feel free to submit through chat. Upon closing the WebEx session, you will also be invited to share your thoughts and feedback through a post-event assessment. We greatly value this feedback and appreciate you taking just a few minutes for completion. I'd like to thank all of our speakers for today, Melissa Dorsey, Carol Moss, and Dr. Newland. And of course, thank you to all of our participants for being with us today. Enjoy the rest of your afternoon.
Thank you, ladies and gentlemen. This concludes today's conference call. You may now disconnect.